Hello, I'm Betty Casey, editor of Tulsa Kids Magazine. We partnered with St. Francis Children's Hospital to bring you important health information for your family. You can find all the interviews on our website and in the magazine. Just look for PJ's Corner. Today, we're here with Dr. Scott Berkman. Dr. Berkman is a pediatric urologist at St. Francis Children's Physicians. Good morning, Dr. Berkman.
Good morning. Thank you so much for having me.
Great to have you. Today we're going to talk about recurrent urinary tract infections. So I just want to start off with, tell us what is a urinary tract infection and what are the common causes?
Oh, wonderful. Well, thanks again. Urinary tract infections can be a viral infection, a bacterial infection, or a parasitic infection. Today we're just going to talk about bacterial infections. And so basically, the urinary tract starts at the kidney. Urine is made in the kidney. The urine travels down the ureter, the tube from kidney to bladder, then ends up in the bladder before you empty. So anywhere along that path is a urinary tract infection from kidney to the outside. And so a bacterial infection would be infection of that system with bacteria. The common causes of infection based on bacterial infections, I guess from the easiest to the most difficult. Easy would be in a female wiping from back to front, carrying some of the bacterial flora to the urethra instead of wiping from front to back. Sometimes urinary tract infections come from anatomic abnormalities. So some structural abnormalities of the urinary tract can lead to stagnant urine, and then urinary tract infections develop from having some anatomic abnormality that need to be addressed or fixed.
Okay, thank you. So what are some of the symptoms that parents should watch for when in their children, and then when should they call a doctor?
Yes, thank you. So you can separate urinary tract infections from upper urinary tract infections and lower urinary tract infections. Lower urinary tract infections involve the bladder to the outside. And so those mostly present with dysuria or burning with urination, urinary urgency or frequency, needing to go to the bathroom frequently, urinary incontinence, leaking urine, blood in the urine. So those would be lower urinary tract symptoms. Once it becomes an upper urinary tract infection, it's basically above the bladder. And these often present with flank pain or pain in the side or pain in the abdomen with fever and nausea and vomiting. And so I guess if those symptoms occur, an investigation of the urinary tract with a urinalysis and some imaging would be reasonable.
Okay, so you certainly would want to call a doctor if your children are having any of those symptoms.
Yes.
Are there ages when children are more prone to UTIs?
For the most part, starting at birth, boys are more commonly getting the infections in the first year of life. Uncircumcised boys have a higher incidence of urinary tract infections in their first 3 months of life. Also, their pressures that are required to empty their bladder are higher in their first year of life. So boys can be frequently getting infections at that point in their life. The girls have infections earlier in their life because their urethra is shorter and the bacteria have an easier time making it into the urinary tract. So the girls will then become the more commonly affected gender after about a year of age. Then dysfunctional voiding when they're learning to toilet train, they kind of both have the same incidence once they're having difficulty toilet training.
Okay, so as they're toilet training, I think parents probably should be aware of some of these symptoms because that could be something that's happening with their child.
Yes,
Correct?
definitely. So I guess burning with urination often, once they're able to talk and tell you that they're having some discomfort or at least have some grimacing, that they notice that they're in pain. I think the infants often will present with fever before parents know. It's hard to pick up that they're having burning or frequency urgency while they're still in diapers and not talking. And so I would say the infants present mostly with fever. And so if the baby has fever and there's no other obvious source, then the urine should be evaluated during the fever workup, which is usually done. But once they start talking and tell you their symptoms, then I guess if they have those concerns, I would probably get a urinalysis and seek some attention.
Okay. Um, is there anything parents can do to prevent UTIs?
For little girls, we always say no bubble baths. It can alter the defense mechanisms of the urethra that are naturally there. The bubble bath can strip away some of the defense mechanisms and allows bacteria to get in. So bubble baths for girls can be an issue. Wiping front to back to not carry the bacteria front towards the urethra. And then elimination and dysfunction is a high risk of infection. So making sure they're emptying their bladders, um, making sure they're not constipated. Those can cause urinary tract infections. So I would say those would be easy ways. And then if they have recurrent infections, having a radiographic evaluation, getting x-rays and seeing one of us to make sure there's no anatomic abnormalities on the inside that predispose to infections, I think that would be helpful.
Okay. Do children always need to see a healthcare professional when they have a UTI, and how would they be diagnosed?
So if they have symptoms of urinary tract infection, then a urinalysis would be indicated. Somebody that's not toilet trained usually requires a catheter to be placed into the bladder, or a suprapubic aspiration where you have to go directly into the bladder through the abdomen to get a urine sample that's sterile. Sometimes if a bag specimen is obtained where they just put a bag over the urethra, it can be contaminated and then confused as an infection. The only time the bag specimen is really helpful is if it's perfectly clear, then you could say there's no need for the catheter and your urine looks good, but often it can be contaminated. So that's a challenge. If they're very sick with fever, you'd probably want to catheterize specimen, get a good sample initially, because once you give antibiotics, then you've now skewed the results of a urine sample. And so getting urinalysis would be the first step. If there is a sign of pus or pyuria or bacteria, then a urine culture would get sent to the lab, and then you can then treat with culture-specific antibiotics once the lab tells you what organism is growing.
Does the child's pediatrician do those things, or is the child referred to someone like you, to a specialist to do that?
Usually the pediatrician will do that. Some will obtain the urinalysis, find the urine sample has either pyuria or bacteriuria, find that there's some bacteria growing, and then be able to treat that. I guess if the patient gets admitted to the hospital, then we often will do a radiographic workup. If it's something that's a recurrent theme, that they're having recurrent admissions for infections, then we'll need to get further evaluation at that point. But the initial setting would probably be the pediatrician to say, yes, these symptoms would warrant a urine evaluation, and then they would proceed with urine evaluation and treatment. And then we usually get involved if it's a recurring theme or if they're that sick that they end up becoming admitted to the hospital.
Right. So, well, I have two questions, follow-up questions then. So these can be serious where a child is admitted to the hospital, and also, so you might talk about that, but how do you define a recurrent UTI, and why do some children have recurrent UTIs?
Yes. So recurrent urinary tract infection would be 2 lower urinary tract infections within 6 months, or 3 within a year. So if they're having these recurrent symptoms, burning, urgency, blood, and then you keep finding bacteria, and you see that at least 3 times a year, that would be recurrent urinary tract infections. They shouldn't be having that many. If you have one with fever, it kind of raises your sense of awareness. Should we be evaluating the urinary tract? The new data says, you could give them one chance to have a febrile urinary tract infection or a urinary tract infection associated with a febrile illness. Now it's kind of moved to 2, but it kind of depends on how sick the child gets and how interested somebody is in pursuing a radiographic workup. If they do end up with a fever associated with the infection, that usually means it's in the upper urinary tract, so that means it's involving the kidney, and that becomes an issue that really should require further treatment and care. And so I guess if they're having fever, this is the lights, the screen's going out a little bit. But let me see.
Oh,
We lost her.
oh gosh.
Are you still there?
I'm here, yeah.
Okay.
There you go.
Oh, there we go. Sorry,
That's
you're
okay.
fading.
That's all right.
So
You're
with fever,
fading.
they often have difficulty tolerating anything by mouth. So if they can't take oral antibiotic therapy, they're going to need to be admitted for IV antibiotic therapy. And so that would bring the child into the hospital.
Okay.
I guess recurrent urinary tract infections for lower urinary tract, we'd still want to work that up 3, 4 infections in a year. One febrile urinary tract infection, you could start with an ultrasound and start working up the urinary tract, but to have a catheter study put into the bladder and evaluate for another condition called vesicoureteral reflux, where urine regurgitates back up in the kidney, we usually wait for the second febrile urinary tract infection, but you can move ahead with that workup if you really feel like there's significant findings on an ultrasound, or if the kids are really getting that sick.
So the treatment is an antibiotic. Are there other treatments?
And so I guess depending on if the child has undergone a radiographic workup, so if they've had recurrent urinary tract infections, then we would start with a renal ultrasound, a non-invasive study, no radiation involved. Basically look at the renal anatomy. Is there any hydronephrosis or fluid in the kidney? Is there any evidence of scarring of the kidney? Are they the same size? Are they in the right location? And that would kind of lead you towards another study called a VCUG, or voiding cystourethrogram, where you put a catheter into the bladder, fill it up with a liquid that shows up on X-ray, see if it regurgitates into the kidney, and define whether or not they have reflux into the kidney. Then there's grades of reflux, 1 through 5. 1's the least severe, 5's the most severe. You usually watch and see if that can resolve over time spontaneously, or that could require surgical intervention. And then if there's fluid in the kidney, then sometimes if it's of a significant degree, we'll have a third study called a renal scan to determine the function of the kidney, and does the kidney drain or is it obstructed? And so I guess if there's anatomic abnormalities, there's more to do. But initially, antibiotics to take care of the infection. So oral antibiotics, if they can take things by mouth and they're not having nausea and vomiting. If they're not taking anything by mouth and are very sick, they come in for IV antibiotics, intravenous antibiotics. And then if they have some of these anatomic abnormalities, sometimes they'll need surgical intervention. And I'm just the human plumber, so if they need that, then I'm happy to fix those things. So reflux, you basically move the tube into the bladder and create a bigger tunnel so that the reflux does not occur. If there's an obstructive part of the urinary tract, then basically take out the obstruction and allow the urine to flow properly. And that usually takes care of their pain or recurrent infections. And then you follow them to make sure everything does well. But our main goal is basically keep the kids happy and healthy, obviously. But in that respect, from my specialty, it's maintain health of the kidneys. And so infections can cause damage of the kidneys. So once you have scarring of the kidneys, you don't really get your kidney tissue back. The liver, on the other hand, can regenerate after an injury. The kidneys don't regenerate. So once you scar and damage the kidney, you've then lost that kidney tissue. And so the ultimate worst case scenario would be losing your kidneys because of recurrent infections, losing your function of your kidneys, or losing one kidney or both. And so those are our goals, are to prevent any renal damage and keep them out of the hospital with urine infections.
So these UTIs can end up being very serious, and parents should take this very seriously. And if they see these symptoms in their children, they should be calling a physician.
Yes, I would say, the lower urinary tract symptoms, certainly if the kids are talking, you could address those early, treat those early, and you have no long-term sequela. If you wait, I guess in an infant, if they have fever and you find it, that needs to be treated within 48 hours. A lot of times, viruses going around town, and they say, well, gosh, in an urgent care, could you potentially just have a virus? Why don't you watch and see how that's going to resolve? I guess with fever of unknown origin, I like to have a urinalysis just to document it's not urine in origin. But I guess if you have recurrent febrile urinary tract infections, which is meaning that the bacteria has made it into the kidney, then you can have long-term sequelae like renal scarring and renal damage. The worst case scenario is if somebody has a stone and the stone has obstructed the urinary tract, and then they get infected proximal or above the stone. And so those kind of situations, somebody would come in with flank pain or pain in their side, fever, nausea, and vomiting. Then you do some imaging studies, and that's really the most emergent urinary tract infection is obstruction plus infection. So somebody with a stone plus infection really needs to be drained right away. They need to be in the hospital. They can get the um, most adverse consequences if
Yeah.
left treated.
Yeah.
Seen that.
So call your health care professional if you have questions about any of this. Do you have any other advice for parents about recognizing, preventing, or treating UTIs?
I would say the prevention will be our most important thing at this point. Maintain good hygiene. For the females, it's more important for, wiping front to back. For the boys, if they have foreskin, they need to clean the foreskin. And if there's problems with the foreskin that they can't retract the foreskin over time, then that can lead to recurrent infections and problems. And then maintaining proper elimination. So if they have underactive bladder or they hold their urine. I hear the kids are, they want to play with their friends, they want to play on the games or do whatever they're doing and not get up and urinate. They hold their urine for an extended period of time. And the urinary tract needs to be emptied regularly, at least every 3 to 4 hours, or the bacteria have a good time and grow and then flourish. And so emptying regularly, at least every 3 to 4 hours, not holding it past that point. And then the other end of the spectrum is an overactive bladder. Some kids have overactive bladders and need some medication to relax the bladder and allow them to hold to 3 to 4 hours. So those two things need to be, I guess, addressed if they see those. And then constipation, for some reason, is very common in some of these dysfunctional elimination kids. So maintaining soft daily bowel movements, I think, is very helpful in preventing infections. And then watching for the signs and symptoms, burning, urgency, blood, and certainly a fever of unknown origin, then I would want them to seek evaluation and get the urine checked.
Thank you so much. That's great information. I think parents really will appreciate this because I can think of a lot of things that I did not know, and I'm kind of thinking back to when my kids were small and wondering what I did wrong, maybe. But
I
now
really
this is
appreciate
great
that.
information. I really appreciate it, and I thank you so much for your time today, Dr. Berkman.
Thank you so much.
You can find all of this information and all of our St. Francis Children's Hospital PJ's Corner interviews on our website at tulsakids.com and in PJ's Corner in the magazine. So again, we appreciate your time today.
I really appreciate you. Call me anytime.
Okay, thanks.